Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Jibanand Satpathy from Virginia, United States. After his orthopedic residency in PGI Chandigarh, India, Dr. Satpathy did higher surgical training in the United Kingdom. He then completed his fellowship in arthroplasty and trauma at the VCU Health System in Virginia, United States. Dr. Satpathy has been doing trauma and arthroplasty for almost 20 years with special interest in Pelvic Acetabular work. He's currently the Director of Trauma in VCU Health System, which is a level 1 trauma center serving the state of Virginia in the US. He has multiple publications with focus on reconstructive surgery as well as trauma, notably on femoral retroversion, as well as periprosthetic and geriatric fractures. If you've noticed, Dr. Satpathy has delivered a couple of lectures on our channel and has already reached a huge audience. And today it's my great honor to bring back Dr. Jibanand Satpathy for this wonderful live program. Over to you, Jim.
Thank you, thanks. Again, good morning, good afternoon, good evening. I'm Dr. Satpathy. I would be presenting about one of the complex pelvic acetabular fracture, which will be a combined ring and acetabular fracture. In short, I'll call it combined ring and tab fracture. I have no disclosures or conflicts in regards to this presentation. This is a very rare injury. It is not very well published and not very well discussed how this would be fixed and the techniques and methodology. So I thought this will be an interesting topic for you guys. The incidence that has been reported is about 5 to 17%. They're typically very high energy trauma. Usual injury severity score is over 20, mostly on an average about 27, 28. There is very limited literature. Again, operative fixation varies. Poorer outcome compared to isolated ring or acetabular fracture. Almost to the point of 20 to 30% poor outcome on whatever limited literature that is available on combined acetabular fracture and ring injuries. What's known? What's known is most common type of fracture on the acetabular side is either a transverse or a T. At least common as expected would be a posterior wall, since the posterior wall would be more posterior directed force and a combined ring and tab would be more like an implosion fracture. It has to be more centrally directed. So thereby that's how they do the ring fracture. So the posterior wall would be at least common type of association in this type of fractures. Most common ring disruption is either an APC, that is anterior posterior compression, or an LC, lateral compression. Mortality is dependent on the pelvic ring disruption. Again, the mortality varies from 13% to 17%, but again, it will be dependent on the extent of the pelvic ring disruption as expected. How do you manage it? Again, the initial management is always the ATLS protocol, always follow the airway, breathing, and circulation in regards to any polytrauma. As I said before, the injury have a significantly higher injury severity score or ISS compared to isolated injury. Now, this is an interesting thing. Pelvic binder can complicate the acetabular fracture, as has been reported before. Patient with a combined ring and a tab fracture, it can actually displace the acetabular fracture. So I put a question mark. I would probably still recommend putting a pelvic binder, but should be taken out as soon as possible when you detect a binder with the acetabular fracture, if possible. Again, this is something reported. Patient with a lower Glasgow Coma score and a higher ISS in this particular type of injuries have a lot higher mortality compared to people with a better GCS and a lower ISS. This has been published on multiple in multiple publications. Now, I'm going to go through the algorithm of some of the cases that I have done and the thought process behind it and how it can help you again, to put an algorithm for yourself and a thought process so that the fixation can be done appropriately. This is my case number one. This is a gentleman, 28-year-old. He was morbidly obese. His BMI was around 42. He weighs about 318 pounds, about 133 or 34 kilos. He had alcohol, cannabis in his system. He hit a tree in a very high velocity. He was ejected out. He had multiple injuries apart from the X-rays I'm showing, but all of the injuries were orthopedic related, didn't have any bowel or chest injury. As you can see in this X-ray, it's a little grainy because of the obesity of the patient. But if you focus on this X-ray, you can see a lot of those injuries just on this X-ray. You can see the symphyseal diastasis that is there. You can see the SI joint disruption on the right side. You can see the obturator ring fracture with the segmental suprapubic ramus fracture there. And you can barely see it here, the acetabular fracture. So again, this is a severe injury, has a acetabular fracture as well as an associated ring injury. Now let's look at some of the advanced imaging to see if you can go through a thought process of how to fix this. On the first axial CT scan, you can see there is a complete disruption of the side joint compared to the other side, the back and front. Both are gone. Theoretically, this is a APC3, but practically, when I see there's a lot more widening in the front and there's a little bit less widening on the back, in my experience, there is some fiber still intact on the back and acts like a hinge and makes it a little bit easier compared to when they're wide both back and front in an equal manner. On the right side, you can see the slide where it shows the transverse acetabular fracture, which is not much displaced. Again, on the 3D scan, you can see the acetabular fracture with the minimal displacement. You can see the ring disruption, and you can certainly see the wide disruption of the SI joint on the right side on the coronal scans. The wall, there's a small wall piece there. It's very small and probably does not require fixation. Now, let's think about it. What are the injuries? We talked about all the injuries we on the previous scans. Now, how do you fix it? What's the sequence of fixation? Now, what's the evidence available? Most surgeons prefer posterior ring fixation first, followed by tab or the acetabulum. That's the golden rule laid out by Letourneau a long time ago. One center uses the inter-ring stabilization with the internal fixator followed by posterior fixation. Preferred approach for many surgeons is a single approach if possible. So as you see, there is no really clear guideline of which way to go on these fixations. Now, these are the questions when I have something like that, I would think whether I should fix the tab first or the ring first. Do I fix the front or the back first? Should I do a closed reduction or open reduction? Again, all these questions, I'm sure every acetabular pelvic surgeon comes up when they see a combined injury. Now, tab or ring, it depends on type of fracture. One thing to remember, your margin of error is minimal for a tab. 2 millimeter or less is your goal. That's anatomic reduction. While ring has a margin of error, your PSI joint is left about up to 5 millimeter. The results are equivalent to anatomic reduction. Although ideally you'd like to have anatomic reduction for both, but you do have a margin of error for the back, but you have a very little margin of error for the front. Now, if you mildly reduce the ring, it will mildly reduce the tab or the acetabulum. So The question is, can you fix both together? It makes the most sense when you have such a little margin of error. If you reduce the back and reduce it wrong, your tab doesn't get reduced, or it has a significant error. While if you go the other way around, if you fix the tab first and can reduce it anatomically, even if you can't get the back perfect, it is probably would be acceptable as long as the margin of error is within a few millimeters or 5 millimeter, which is published. So let's go to what you need, back or front. You need a hinge to, at one side has to fix, so you can make it a hinge and fix the other side easier. So it makes sense to fix the front first because you have direct access to it. You're able to visualize the front. And if you can get the front perfect, the back is only essentially there is a gap, and then all you need is a compression because they're all connected. If you get the rotation right and the reduction on the front right, all you need is the backside to compress it. And it just makes sense to fix the front first in a lot of the cases. So, however, the golden rule is back first. But again, I don't believe we should go with the all black and white. This is something you have to go case by case. And in my experience, it has been a lot more easier to fix the front first and get the back after that in majority of the cases. So open or close, always attempt close reduction first. If it fails, then go for open reduction. I'm talking about the back. If you go to the back for open reduction, typically it's a prone posterior approach. It can be done through an anterior approach, lateral window with the anterior plating. You need to have experience in it. The L5 nerve root is pretty close. There's a high risk of neurovascular injury. And typically it's a double plate and 90-90 for anterior sacral plating or SI joint plating. But it can be done. Now, coming back to our case, what did we do? What we did is what I said to the algorithm. We felt it will be a lot more easier to hold the reduction on the front and provisionally and work simultaneously on the back. If we reduce the front, then we felt like the back will be reduced. The only thing that complicates in this fracture is the broken obturated ring on the right. So we knew this would be a potential problem, and you should think about it, because even if you close that hinge here on the front, your hinge kind of moves here and this part still wiggles, so that it may not reduce the SI joint perfectly unless we span the entire surface with a plate bilaterally. And in this one, the thought process was we would try this, but we knew that very likely we have to go to the back because the ring was comminuted and we were not certain we can get perfect reduction on the front, and we didn't want to jeopardize fixing the front here imperfectly and get again unable to reduce the back even close to 5 millimeter. So what we did is we reduced the front like we planned. We wanted to reduce the acetabulum anatomically. So we applied a distractor and used the pins essentially as a provisional external fixator. We put a supraacetabular pin on the right, and then we put another iliac crest pin on the left, and use that to our advantage. You can see our clamp where we reduced the front and held it with the clamp. And once we provisionally fixed the front this way, our tab was pretty much anatomically reduced. So all we need to do is to put a posterior column screw and and an intercolumn screw on the front. And you can see there's the intercolumn screw, there is a posterior column screw. And you got anatomic reduction of the acetabulum with a congruent joint. As you can see, we stayed short of the obturator ring because as I said, we were not sure we can get anatomic reduction of the front and accommodated pelvic ramus fracture. So we provisionally fixed the back with a short sacroiliac screw. And you can see the reduction is not perfect. It is more than 5 millimeter on the back. So our plan was to flip him prone and reduce it openly, going on the backside through a posterior approach. So then we went on the backside, and as you can see, there's a clamp placed from backside to inside to reduce the side joint. It is again not perfect, but it is close to perfect. It's less than 5 millimeter displacement, actually 2 or 3 millimeter widening on the front. And we applied 2 screws this time, a S1 screw and a S2 screw to have a better fixation. This X-ray is 2 years post-op. The fracture is remodeled and healed in the ring. The joint space is well maintained, and the SI joint is held well. The screws are holding well. Everything is healed. This guy was actually really doing well. He recovered from all of his traumas, including the pelvis fracture, and back to his normal life. So that was the first thought process in the first one. I'm going to go to the case number 2. Again, principles of fixation is anatomic acetabular reduction. Up to 5 millimeter of mild reduction is acceptable for a SI joint. If possible, provisional interfixation helps with the posterior fixation. Although posterior fixation should be done first, acetabulum fixation is critical because the margin of error is very little. Mal reducing the posterior ring will mal reduce the tap. So if you go for posterior ring first, you have to make sure that you reduce it perfectly. Otherwise, I would recommend start from the front first. Now, this is case number 2. This is a 51-year female with some psychiatric history. She was in a parking lot, and a car came at a high speed, couldn't stop, and pinned her to the wall. Pretty high energy injury. She had significant pelvic acetabular fracture, also had a severe degloving injury to her right posterior thigh, exposing entire posterior thigh with a neurovascular bundle exposed in the popliteal fossa on the right side. She also had an open femur fracture, supracollar intercollar on the right, but our focus is on the pelvic injuries. She did have belly injury, required bowel resections, and chest injury with the chest tube. So she had more injuries than just fractures. So once she was optimized, stabilized, and then this is where we were involved. Now, if you look at the X-ray, it doesn't justify how bad is the injury. It actually looks like a standard both column acetabular fracture. It's a bad one, but compared to what I'm going to tell you, this is not as bad. Now, if you look at the X-ray more closely, you can see the symphysis there. They are not at the same level. There is a symphyseal diastasis, which is very subtle and doesn't look bad, but intraoperatively, this is completely unstable. Then what is not visible on the back here is the SI joint or sacroiliac joint bilaterally is disrupted, and left side is a complete disruption as well. So now the question is, you have really no hinge anywhere. The front is completely disrupted. The back is completely disrupted. You have a huge iliac wing or the anterior column that goes all the way up, almost to the backside. Then you have a both column fracture. There's a posterior column which is displaced too. Now, let's look at it more closely. Now, the 3D reconstruction does not justify what was actually visible there. It does seem like the posterior column was intact. There was actually a hairline fracture on the axial CT, but by the time we were in the operating room, this was completely displaced. The posterior column was completely off. So there's a huge posterior wall, and you can see the anterior column fracture goes all the way to the backside of the iliac crest. And then you can see the other side, there is a transverse acetabulum fracture. The SI disruption is not clearly visible here. Symphyseal disruption is again is being masked. So let's think about it. Now again, these are some of the pictures you can see. Bilateral SI widening. This is actually a lot worse than it is visible. And intraoperatively, this was grossly unstable. In the left SI joint, you still have some widening of the right SI joint. You can see the iliac wing is completely off. And then you can see, if you want to see, there's a slight disruption of the symphysis pubis, just to give you some clue that there is something going on the front too. Now, what we did. Now, this is some of the more of the final pictures. So again, the thought process is, how do you fix this? Do you fix the front, back? Again, the same question comes. Now, what you have to remember, you have to have a hinge. Without a hinge, there is no fixation. Everything is floating here. So how do you make a hinge on this one? The easiest one would be an anterior intrapelvic approach and go on the front. And we also did the lateral window. If you're familiar with this, in the ilioinguinal approach, the first window is your lateral window going right along the crest of the ilium. For the surgeons who are not familiar with this approach, I'm sure a lot of you folks know exactly what to do. But basically what we did is we did an intrapelvic approach, AIP, and then did a lateral window to be able to access the backside as well as the front side. So the first part was to get the symphysis together. So we put a clamp to hold the symphysis provisionally fixed with a K-wire to have some sort of semblance there, get something up the front. Then we worked on the back, on the lateral window, and fixed the iliac crest with a single screw there. Under direct vision, this was anatomically reduced. We still don't have a complete hinge yet to fix the back. We still have a disruption of both column here. So since the iliac crest was fixed well there, and we have a pubic ramus that is connected now, it was easier for the anterior column to be directly reduced. We put a wire through the displaced anterior column and sequentially compressed it to reduce the anterior column. Now we have a nice hinge. The front is pretty much fixed. We had not fixed these screws on the backside yet. We just put the plate, slid the plate along, and hold the anterior fixation. Once I have this, then it was very simple to put an S2 screw. You can see the long screw, which is called a transiliac transsacral screw, which goes all the way from the left side to the right side. And we couldn't put an S1 screw because the sacrum was dysmorphic, which means it was not conducive for an S1 screw to be placed safely at that level because of anatomic abnormality of the S1 level. So that reduced the entire left side. As you can see, again, we used the principles of fixation where we wanted it to the tab to be, or acetabulum to be anatomically reduced. The only way to do that was to have some sort of easier fixation, get it peripherally there on the backside of the iliac crest, and then get the symphysis. We have a hinge back on the front and back, and then we could easily put an anterior column screw to reduce the anterior column. It still doesn't solve all the problem. We still have a fracture on the right side. Now, unfortunately, because of severe degloving on the right side, we had really no good access to go and reduce it. This would normally require a posterior approach or Coker-Langenbach approach to reduce this transverse acetabulum fracture because the posterior column was rotated and we couldn't derotate from the front. So we attempted to close reduce it, and we got a reasonable reduction. It's not perfect, but we could put an intercolumn screw on the right side as well to hold the reduction, and accepted that. So then we flipped the patient, went posterior for a Coker-Langenbach approach. Now there's no way to reduce this large posterior wall from the front, although ideally we would like to have single approach, but this is more complex. And then that, and it would be very difficult just to go through one approach because of the large posterior wall. The other thing also, because patient had severe injuries, was on ECMO for a little bit, our surgical time was delayed. By the time we were doing the fixation is over 2 weeks. So we had to openly reduce the backside. So we went to Coker-Langenbach approach, and then we reduced the wall piece in the column with a single plate and a couple of lag screws, and then a couple of spring plate to buttress. And if you're not familiar with the spring plates, these are like diving boards with little tines on the front. This is made by a specific company, but it is a real useful tool to have buttressing of the posterior wall, specifically if you have smaller pieces. These are very useful. I find also on a bigger pieces, this is nice to buttress it at the periphery. This is a post-op CT showing nice intercolumn reduction. You can see it's anatomically reduced. Same thing for posterior column. It's nicely reduced with the congruent joint. You can see some of the right side as well. It's a slight mild reduction, but it's quite medial, and was acceptable both on the X-rays as well as on the CT scans. So that outlines our second case. Hopefully it was helpful. That third case is a little different, and I wanted to show this because it has this little bit of more common type of injuries that you might encounter than the severe injury that we just discussed, two of them. This is another gentleman, a 30-year-old male who was in a high-speed head-on collision, presented with this isolated pelvic fracture. He didn't have any other injury, fortunately. If you see the 3D reconstruction, you can see the anterior column is disrupted, and then on the flip side, you got a posterior column disruption there. You got a wall, and as we discussed in our previous acetabular fracture topic, the ring is not disrupted, so that makes it a transverse posterior wall acetabular fracture. Again, if you can see it here, you can see the SI joint on the right side is wide. And this is not a very uncommon situation. You see in a lot of these transverse fractures almost behave like a ring injury, where instead of disruption of the obturator ring, the disruption is through the acetabulum with the widening of the SI joint. Is almost like an APC injury with the acetabulum fracture. Now, if you see on the CT scan, is a lot more evident. The APC2 SI disruption, you can see the hinge on the back is intact, and on the front is a fairly wide disruption. Again, if you think about it, you can argue that this is nicely bare, and you can compress it in the back and then reduce the tab. Again, I find it is, although that's possible, I feel like if you don't get it perfectly perpendicular to the joint line, it may not reduce it perfectly, and then your acetabulum would be hard to reduce, and you may have some imperfection there, could be detrimental ultimately to the fixation of the acetabulum. So again, my thought process for this one would be fix the front first, fix the one that requires anatomic reduction, I can accept a little bit of widening on the back if I can perfectly reduce the front. Typically, if you reduce the front perfect, the back should fall back in line. Now let's look at some of the CT scans there. You can see the transverse fracture goes right through the dome, which is a transtectal transverse fracture, almost juxtatectal. Then you have your posterior wall fracture, and you can see a large piece of articular surface is in the joint. So what do you do? Again, like I said, for me, the fixation of the acetabulum is critical, and I want to make sure that I get a perfect reduction for this tab. Now, coming back, if you think about it, should you go front first on this one? Should you be doing a lateral window or AIP to reduce the anterior column first, or should you be going a cochlear along the back and try to get everything from the front? Now, one thing to notice on this picture that I wanted to show you, if you see that anterior column is broken here, but then a horizontal line goes all the way across, that separates this pubic ramus or medial segment of the anterior column completely from the posterior column. This would behave almost like a T fracture. You will not be able to control the front by fixing the back. And this is an atypical pattern, but not very uncommon. This is classified as a T fracture by definition because your ring is technically intact. However, if you look at this 3D CT, the line actually goes all the way across the column, separating this segment completely from the posterior column. Now, if you reduce the posterior column well, the anterior column may not reduce, and you have really no access to control that top piece. You cannot reduce the anterior column by fixing the posterior column. So this is something you should be prepared for a dual approach. Going on the back first, because there is a big posterior wall and you have a chunk of articular surface in the joint, that the easiest way to take it out would be from the posterior side. So you really want to go posterior first in this one. That would be the thought process for me, and that's how decisions you would make, like which way I go. This is very clear once you think about it, that cochlear lung and back is a straightforward approach for you. So that's what we did. We did a cochlear lung and back approach first. This is a sage pin that is in the neck, and that we use to pull the head out so we can take the piece out, which we did. And that piece was positioned appropriately and bone grafted on the articular surface and then held well with the screw. And then you can see a couple of lag screws and a buttress plate and a neutralizing plate for the column, as well as a buttress plate for the wall piece. And this is anatomically reduced posterior column. Once we reduced the posterior column, we we flipped the patient, went supine. We did a AIP. We did a iliofemoral approach on this one, using the first and second window of the ilioinguinal. And then we also did an ASIS osteotomy. We took a piece of ASIS. I'm sure you're very familiar with this technique. We put a square block of ASIS using a TPS saw, separated it out so that we have access directly. Essentially, extended the lateral window to the second window. Once that was done, we put an angle clamp, as you can see on this picture, and we could nicely reduce the anterior column anatomically. The only issue we had, we had some access issue when you tried to put the wire for the anterior column. We had difficult time negotiating the wire to get a nice long screw. You can see, if you notice, the wire is bent. This is actually a described technique by Chip Rao. He does use a different K wire specially made for him, but we found that we can use our standard 2.8 millimeter guide wire and bent it slightly at the tip. Now make sure if you bent it, do not drill it. You have to hammer it. So typical technique would be use the guide wire up to the level where you want to change the direction. Then you over drill it right up to that level. Then you bend the wire and then gently hammer it, mallet it to the direction you want to go, which is what we did. And we could nicely negotiate that wire to our desired place, getting a very nice long intercolumn screw. It had an excellent bite. You can see it compressed the fracture really well. You can't even see the intercolumn anymore. This was nicely reduced. Now, some of the, for the folks who are new or postgraduates who are listening, typically intercolumn screw, you would require a uptrader outlet and an iliac inlet view. The uptrader outlet view shows if you're superior or inferior. Your iliac inlet view shows if you're anterior, posterior, inside the pelvis versus outside the pelvis. And then that's the typical views you would use to reduce it. So then once we are done with the tab fixation and this is anatomically reduced, we put our SI screw and then you can see it's nicely compressed the fracture. Because the tab is 100% reduced, the SI joint would typically reduce really well. A single screw was sufficient. Is a young guy, good bones. We could nicely compress it. And this single screw is to hold the intersuperior spine osteotomy that we used. And then that fixation is good. Patient is doing well. He's only about 2.5 or 3 months out. Still a long way to go. But you can see the reduction is anatomic. You have nice intercolumn reduction, the very good postercolumn reduction, completely anatomic reduction, and then everything else is being held really well. So coming to summarize my talk, there's no golden rule for fixation. You don't have to go posterior first on a ring and tab injury. My preferred approach has been to fix the front first if possible. I feel like a reduction is a lot more easier and you can visualize it better on the front than on the back. If you fix the back and not reduce it perfectly, it is very difficult to get the acetabulum reduction better. Remember, acetabulum reduction is more critical. The margin of error is minimal. So you really have to get that right. Some sort of imperfection on the back is typically acceptable as long as it's not significant, as long as it's not more than 5 millimeter. As I said in the first case, when you didn't get it perfect, we did open it and openly reduce it to get it back to less than 5 millimeter. So there's always an option. If you have to go back, you can, but remember, don't burn your bridges. Like we didn't fix the on the right side on the front, the first case, to make sure that there's some flexibility on the back. Again, these are rare injuries. They have a lot more severity of injury. They're usually polytraumas. They have poorer outcomes compared to isolated pelvis or tab fractures on its own, with almost 20 to 30% reported poor outcome on many cities. Hope that helped you, and hope this is a useful talk. Please feel free to email me or contact me if you have any questions. My email would be jibanananda.sapathi@vcuhealth.org. You can reach to Dr. Hitas Gopalan as well, who will be, I'm sure, happy to direct any questions to me as well. Thank you very much.
Thank you, Jiba, for yet another brilliant presentation and some excellent case examples. Few questions, Jib. Jib, what is the timing of fixation for your acetabular fractures? Other than an open fracture or an incarcerated fragment, what is the general time period? I remember many years ago, people used to wait, say, around 7 days until the edema, all soft tissue swelling settles down. What is your experience?
So it is, some of these patients are are so sick that that determines timing sometimes. Like my second case, that I had to wait almost 2 weeks. Patient was on ECMO. We didn't know if she's going to live or not. But typically, like the last case, we did it same day. This patient was an isolated injury, so sooner is better. This is a lot easier. Out of all 3 cases, third case was the easiest fixation, and we could get it the most perfect, because the sooner you go, the easier the reduction becomes. So our policy has been as soon as possible, as soon as the time allows, as long as they're stable. We tend to do lactates and make sure the lactate is normal or less than 1.8 for us here. So as long as the lactates are normal, all the scans are negative. Typically, they get evaluated really well. I was a level 1 trauma center. They all get pan scan. They all get a CT chest, abdomen, and pelvis, and many times CT head. So typically, there's no missed injuries to go quickly for us. And all the labs, specifically lactate, has to be normal before we go into the OR on these cases. So to answer it simply, ASAP. Doesn't have to be in the night. Obviously, we don't like to do in the night, but certainly as soon as possible.
Thank you, Jim, for that. And just technical points. How regarding the entry point for those anterior column screws as well as posterior column screws? In one of the pictures, I think the posterior column screw, if I'm sure as it was the first case, you put the posterior column screw from the AIP approach, is it? And through the plate, isn't it?
Right. Right, so I have done, typically for posterior column screw, you have to go through actually a lateral window. AIP wouldn't help, it is hard to put through AIP, but typically it'll be a lateral window. So even if I do AIP, about 80% of time, I would do a lateral window because it's easier to put those screws that way. Also, it's easier dissecting out. Many surgeons don't do it. I tend to do a lateral window. For my posterior column screw, again, typically you do a obturator and iliac oblique simple views to get your entry point for the typically it's closer to brim. I like to go through a plate. That's an older case. So more recently, I've been putting thicker screws like a 6.5 or 7.3 screws. Sometimes even 2 screws. And then if I put those bigger screws, then obviously you don't go through the plate and I go out of the plate. Entry point is 2 to 3 centimeter anterior to the SI joint, typically. But again, all depends on how the views look at it, and you guide your wire and the posterior column, in the best way possible that way. For my anterior column screw, typically I find iliac spine and go about 2 to 3 centimeters behind it. And then position wise, again, you start with the obturator inlet view and see where the wire directs you best. I mean, don't go with the theory of that cross point, you marking. Our patients are so obese, and many times there's so muscular or bigger people. It isn't just not easy to go with a specific landmark. So the only thing I do will be AIIS as my landmark. It's easier to find that area and go an inch or so behind AIIS as my starting point. One thing I have done, Hitesh, as well, is to use this as a thinner wire, like a K wire, 2 millimeter K wire, to find the entry point, and then use that to over drill with that, and then do the 2.4 millimeter or 2.8 millimeter wire after that. I find that it's a lot more easier to manipulate 2 millimeter K wire than a thicker wire.
Thank you, Jim, for that. And just one last question before you wind up the session. With regards to fixation of the sacroiliac joint, how often do you do an anterior SI joint plating?
I typically don't like anterior SI joint plating because it has to be a double plate, and I feel like it's not as robust. So I have mostly done open posterior approach. More recently, as I have been like I showed you, if I fix the front, typically the back falls back together. It will be a rare incidence where I have to, like I showed you one of those pictures, this would be one of the rare cases where I actually had to do open reduction. If I have to do, say, if it is a really vertical comminuted sacral fracture that you have to kind of get point-to-point reduction. Then I typically would do a lumbopelvic fixation. I'll get my lumbar spine guy, and I would put a SI screw, and then he would add a lumbopelvic fixation to that by openly reducing and decompressing the sacral nerves.
Thank you, Jibs. I think that's all the questions that we have for this session. Fantastic lecture, amazing case examples, and I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much, Jiba, for joining.
Thank you, Hitesh. Thank you very much.
Bye-bye.